Okay, so hey, let's do this one more time. Welcome everybody to our lab today, and thank you for those of you that have been putting up with me because technology did not work the way I would like it to, but now we're good. All right, so we're gonna go over some stuff that we went over in lecture, just to make sure that we know the parts and everything, and then we're gonna watch couple of little videos interspersed throughout today, but it shouldn't take today should be a pretty short lab. All right, so let me go ahead and share my screen. All right, so pull out your lab packet and let's go ahead and go through our stuff. Okay, so cerebrum. Here are two different views of the cerebrum. Here we can see it from a superior view. We see the two cerebral hemispheres, so you can see her cerebral hemispheres are there. And then here again is the cerebrum, the highly convoluted, and like 80% of what your central nervous system is your cerebrum. So the cerebral hemispheres divides up the work basically so that one half can do some jobs and the other half can do some other jobs. Longitudinal fissure then is this line, is very deep sulcus that goes down through the middle of the cerebral hemispheres from anterior to posterior. So that's a mid-sagittal mid-sagittal fissure that we have right there. Okay, then let's just go into the different lobes again. So this is a good picture to show us that. Let's go to this picture. No, it's not that one. Yeah, well, let's just do this one. Okay, so frontal lobe is here in the front, underneath the frontal bone. Here is the parietal lobe, underneath the parietal bone. Here's the occipital lobe, underneath the occipital bone. And last but not least, here is the temporal lobe, underneath the temporal bone. Okay, then, like I've talked about already a couple times, here is the gray matter that is made up of unmyelinated everything. So anything that's unmyelinated is going to be in the gray matter, primarily entire interneurons and dendrites and cell bodies, but there may be some portion of the axons that may be in the gray matter as it now then extends down into white matter. And then the white matter or the medulla is the myelinated everything. So here, since we're in the brain, we know that this white matter is going to be myelinated with oligodendrocytes. Make sure you have that relationship. Okay, so white matter in the cerebrum, oligodendrocytes on the axons. Gyri or a gyrus is one ridge. So gyrus, gyrus, gyrus. Excuse me, and then the sulcus are the grooves. Oh, excuse me. Okay, so the sulcus are the grooves. So there's a sulcus, there's a sulcus. Okay, so, and even though this says fissure, it'd be like the longitudinal fissure they're talking about. Well, actually, they're talking about one of these fissures right here, like this lateral sulcus. So don't really worry about fissures other than that longitudinal fissure. Just sulci are good because we have the lateral sulcus, we have the central sulcus, parieto-occipital sulcus. That's all the specific sulci that we have. Okay, and then we have a cerebellum. So here's our cerebellum, and I want to show you something in the cerebellum in a mid-sagittal view. So we may or may not come back to that picture. Okay, so here you can see a little bit. We're going to talk about all of this tomorrow in lecture. But if we take a look at a cross section or a long sagittal section, sorry, of the cerebellum, you'll see something kind of neat in it. Okay, if we look at how the white matter is organized, I'm going to go to one more picture. As soon as I can find it. It's the one I want right here. Okay, so if we look at this how the white matter is organized, we can see there are a lot of sulci, very narrow sulci and gyri here in the cerebellum. And so as the folds undulate here through the cerebellum, we get the white matter looking very tree-like. And so that tree-like white matter of the cerebellum is known as the arbor vitae, or the tree of life. And so that's the arbor vitae, or arbor vitae, or however you want to say that. Okay, so what I want to do right now at this point is stop this. So let me stop sharing. And then I want to go into one of those topics that I want to watch today. So I don't know why this one that I want to watch did not embed, but anyway, we're just gonna go there and watch this. Okay, so let me play that.
I'm Kara.
And
I love making love.
Oh, that's nice. Okay, that's
in
gross.
the grand scheme of things.
Okay, so
The
whoops.
extraordinary certainly.
All right, so just never know what's gonna pop up when you're on YouTube. All right, so we're gonna go ahead and make this big, and then I'm gonna share it, and we'll watch this, and then we'll talk about it. Okay, play.
Really happened to Phineas Gage on September 13th, 1848. Unfortunately for Gage, that extraordinary thing was pretty gruesome. Here's why Phineas Gage is still fascinating, even today. What happened? 25-year-old construction foreman Phineas Gage was helping cut a new railway bed through Cavendish, Vermont, and was using a tamping iron to pack explosives into a hole. And then, this happened. The explosives detonated early and sent the 4-foot, 13-pound tamping iron through his left cheek, into his brain, and out his skull. Making things worse, according to legend, he might not have even lost consciousness. Historical documents say that he was driven into town where he sat on a porch chair and chatted to passers-by as he waited for Dr. John Harlow. After a few days, he developed a brain infection that left him even closer to the Grim Reaper's door. But the Reaper had apparently been impressed enough with what he'd already survived to give him a pass. He recovered, lost use of his left eye, and went home 2 months later. Everyone who knew him before and after the accident agreed he had changed. And when he died in 1860, after suffering a series of seizures, he remained a part of historical and medical infamy. Pioneering neurology. Gage is one of the earliest documented cases of traumatic brain injury, and his accident couldn't have come at a better time for the science of neurology. When Dr. Harlow first documented Gage's story in the Boston Medical and Surgical Journal in 1848, no one believed it. It wasn't until 1850, when Harvard professor Henry J. Bigelow wrote a piece on him being a fully functional human post-accident, that people started to notice this medical miracle. Bigelow's follow-up report in 1868 focused on the mental manifestations of the accident, saying he had become fitful, irreverent, indulging at times in the grossest profanity, and manifesting but little deference for his fellows. In short, the guy who got a giant metal spike through his head allegedly became a jerk. Neurologists at the time insisted that we needed to look inside the brain to unlock the secrets of what made us human, and Gage was the first documented case that provided evidence for this. So we should probably be thanking Gage for his unwitting scientific contributions. Insane in the brain. There's still a ton we don't know about brain function today, and we can't always peek inside to see what's going on, so we have to find other ways to get a look. Gage's accident and his big, open brain was helpful in doing just that. We know what part of his brain sustained the most damage, the prefrontal cortex, and we know what happened to him afterward. His memory was intact, and he was perfectly capable of working, traveling, and doing everything else a responsible human should do. But everyone also agreed that his personality underwent a big change, which was pretty good proof that our personality lives in our prefrontal cortex. While some sources say post-accident Gage was a depraved monster.
I'm still the same man. You're the same man! Look at yourself, Phineas! Give me my job! Give me my job back!
Other documentation shows he managed to maintain a pretty normal life. It is also written that he exhibited himself in freak shows, and that he had no more social inhibitions, was a perpetual drunk, and even that he was described as psychopathic.
He's like an animal now.
An animal's emotions in a man's body.
But there's nothing in Dr. Harlow's writings that suggests anything of the sort. And his mother testified he was eager to keep working after the accident and loved making up stories to tell his nieces and nephews. Psychopath, storyteller, or something in between? No one's entirely sure. New insight. Technology has come a long way since Gage's accident, and it's a lucky thing that we still have his skull. The official cause of Gage's 1860 death was complications from epileptic convulsions. No autopsy was performed after he died, but Gage's body was exhumed 7 years after his burial, and his brother-in-law took both the skull and tamping iron to Dr. Harlow. Today, both artifacts are housed in Harvard's Warren Anatomical Museum. We don't have any direct information about Gage's brain, but we do have two of the most important tools needed to recreate what happened to him. His skull was mapped and diagrammed as early as the 1940s, according to NPR. And as technology has improved, we've gotten increasingly better looks. In 2012, researchers from the Laboratory of Neuroimaging used a combination of techniques to map exactly what connections were severed when the tamping iron sliced through his skull. We found something pretty interesting. The white matter in Gage's brain likely sustained damage less severe than you might expect, similar to the damage done by a typical brain lesion. Pretty lucky for such a seemingly unlucky guy. We can overcome. There's a lot of gory stuff that's involved in talking about Phineas Gage. He's still the poster child doctors point to when they want to show patients and their families what the human body and brain can overcome, even without the miracle of modern medicine. If there's one good thing to come out of Gage's insane, life-changing accident, we think he'd be happy to be an inspiration to people going through similar life-altering traumas, which is pretty fascinating. Thanks for watching. Click the grunge icon to subscribe to our YouTube channel.
Okay, so that just gave you a quick summary of Phineas Gage. That recreation, you know, they showed the tamping bar, the actor, you know. I actually have that video that I always show to my students when we do this lab, but I didn't. It's like 15 or 20 minutes or something like that. So I just found this little snippet, but what I need you to watch on your own, I'm not going to have you watch it now, but if you go to the second video under Phineas Gage, it gives you a little bit more information, and it's really on what is the real story of Phineas Gage. But tomorrow in our lecture class, then I'll talk more about the prefrontal cortex, our personality, and then a part of our brain called the limbic system, and what they think happened between when the tamping bar went between the prefrontal cortex and the limbic system. So that's kind of cool, but we'll talk about that tomorrow. So make sure that you watch the video on underneath on Phineas Gage as well. Okay, the next video that I want to show you is the unfixed brain. And so what that means is that when we remove an organ from the body in order to make sure that it stays preserved so that we can study it for a while, obviously that we put it in formaldehyde or formalin so that it doesn't decay. But when we put it in formalin, what that's going to do is denature the proteins. So the texture and the structure of the brain becomes more rigid so that it doesn't get smushy. But the brain is actually smushy, you know, how technical, how anatomical is that? The brain is kind of squishy and smushy. And so when we put it in formalin, then we fix it, we harden it, we make it so that it's not smushy anymore. So before we put it in formalin, then we say that it's an unfixed organ. And so I'm going to show you a video on the unfixed brain to show you what the actual texture of the brain is like before we put it into a vat of formalin. So this is really good. All right. Okay. Let me know if you can't see it. Somebody chat me if you can't see it.
Students think that the brain is sort of the consistency of a rubber ball. And that's because in the laboratories and teaching specimens, we have fixed, formalin-fixed brains. However, if you're a trauma surgeon or a neurosurgeon, you realize that the brain is really very, very soft and much more vulnerable than the impression you get looking at the fixed brain. So I would like to show you a 1,400 gram brain that has just been removed from an autopsy. And we are fortunate enough to be able to show you what a normal, unfixed, recently deceased patient's brain would look like. This is the ventral surface of the brain. And what you see are the Peel vessels, this nice blush with the clear leptomeninges and the vessels running in between the arachnoid and the pia. The cerebral spinal fluid has leaked out through the cisterns, and so the subarachnoid space is no longer visible unless I move the brain, but it's very, very soft. Notice, it's totally squishy. It's the consistency, it's much softer than most of the meat you would see in a market. So if I were to pinch this in either way, I could easily damage this with my thumb. In fact, neurosurgeons, when they are doing surgery, often just evacuate with a vacuum or suck out parts of the brain. This string here has been placed around the basilar artery so it can be suspended in a bucket of formaldehyde in order to denature the protein and harden it. If we didn't, it would sit on the bottom of the bucket and the brain would become deformed, as you would see here, so that it would be compressed in this direction just from the weight of the brain. So that points out one of the purposes of the cerebral spinal fluid is to float the brain inside the calvarium and act as a cushion. The cerebellum is easily seen, the medulla, the pons. Here you can see the arachnoid spanning across the space here at the base of the brain. The optic nerves are very obvious, as are the olfactory nerves. Here are our temporal lobes, and here is the uncus on either side. The uncus, remember, is the most mesial part of the temporal lobe. The tentorium that fit in here has been removed, but we can see a slight groove right along here where the tentorium sat. So there is no evidence in this brain of any of the temporal lobe herniating medially over the edge of the tentorium. It's a beautiful specimen. Unfortunately, this cancer patient died of complications secondary to a cell transplant. Here you can see how soft and pliable the dura is, and we can look down between the hemispheres and see the corpus callosum. I can also see a bit of the anterior cerebral artery coming over the surface. So this is the interhemispheric fissure. And if I turn the brain around and we look at the occipital lobe, we can see the top of the cerebellum. And here there is a very small amount of blood that was actually seen on MRI that the patient had before death. If I let the cerebellum hang down a little bit, you can see the superior surface of the cerebellum. Turn it back around. So our very delicate and vulnerable brain, with its two vertebral arteries on the medulla, its basilar artery on the pons, it's branching to the posterior cerebral artery right here where you have the cerebral peduncle, and here we have the space here is the interpeduncular cistern, and we can see the two mammillary bodies. The pituitary gland stayed within the body, and here you can see the base of the brain with the optic nerve, the chiasm, and the tract. You can see here an impression, a depression just from where I was holding the brain. Just from holding it that small amount of time, the depression from my finger is clearly visible. Think how vulnerable the brain is, then think how narrow and small the spinal cord is, and what a devastating consequence just a quick subluxation of the vertebra or a herniation of the disc can cause to the delicate spinal cord, which is about the width of one of these gyri. These gyri are nice. There's no big space between them. but neither does it look particularly swollen for a patient of this age.
Okay, so I love that video. Love taking a look at that brain. And so we're going to look at something now. Let's see, at least one more video today. Maybe two. Uh-oh. Oh, that's didn't post right. Dang it. Okay, well, I'll have to make a correction to that as I go down through my stuff. All right, so let's get out of that and then take a look at some more things that I want to show you, and then we'll watch the subdural hematoma video. So let's see. So on our list, what I want you to go to now is over on the second column. There's just 4 words there: meninges, and then dura mater, excuse me, arachnoid mater, pia mater. So we're going to go to that next. If you have your lab manual, we're in exercise 17. And so we're going to take a look at, all right, okay. All right, so we're going to look at the material that covers over your brain. So we're going to go from the very outside to go into the inside. So here we are in the very outer surface of your brain, or outer surface of your skull, your head. So we have the scalp, which you're all familiar with. And then we're going to have the skull bone, but of course we're going to have periosteum between the scalp and the bone, because periosteum is going to cover all bone. So scalp, periosteum, skull, and then we're going to have the outermost layer of the meninges, which are connective tissues that surround your brain, called the dura mater. And the dura mater is very thick. It means tough mother. And there are actually 2 layers to the dura mater, this periosteal layer, meningeal layer. You don't need to know the difference, but you do need to know that these 2 make up the dura mater. Then beneath the dura mater, the second layer of the meninges is called the arachnoid mater. And so dura means tough, arachnoid means spider. And so here we have this spidery web-like meninges that produces an opening, a subdural space or a subarachnoid space. This subarachnoid space is going to be filled with cerebrospinal fluid to help float your brain inside of your skull. Tomorrow we'll talk about what happens when your brain doesn't float inside of your skull and how extremely painful that can be, because it happened to me. And then the last layer of the meninges is the pia mater, which means gentle mother. And so that's actually touching the brain itself. It's going to go over the top of all the gyri, and then it's going to extend down into all the sulci. Okay, just like that. So the outermost layer, dura mater. So dura mater there, arachnoid mater, and then the pia mater. So let's go to a different representation of this actual photograph of the meninges. So in this diagram right here, we can see the dura mater is this thick that doesn't allow us to see what the brain structure actually looks like. So outermost layer, tough layer, dura mater. When we remove the dura, now you can see, oh yeah, I can see the brain now. Let's go to just this picture. Okay. So dura mater, you can see I also have meningeal blood vessels running through the dura. And then if we go down here over the spinal cord, this is this very thin looking material, but it's still obscuring the spinal cord a little bit. So they remove the dura. Here we can just barely see the edges. Let me get something to draw with. And just do the very edges. So here the dura has been cut away over here, and then we cut it over here. And so now we can see this is the arachnoid mater. Okay, so here was the dura and the arachnoid, and now they don't label that, but the shiny that we find that's actually touching the brain, then that's going to be the pia mater. Okay. All right. Okay, so this tentorium cerebelli and the falx cerebri and the falx cerebelli, these are all where the connective tissue, where the meninges goes down between the parts of the brain. So down here in this longitudinal fissure, not the sinus, because that's this blue blood vessel right here, but the connective tissue that goes between the two hemispheres, falx cerebri, tentorium cerebelli goes between the cerebrum and the cerebellum, and it's in case, and then the falx cerebelli then would go between the two hemispheres of the cerebellum. Okay, oh, is there one more? Let me see if there's one more picture that I want to look at. Yeah, let's go ahead and look at this, because I'm going to talk about, I'm just tell you my story right now. Okay, so when you have cerebral spinal fluid, so it's going to, like we talked about last week, I guess, or sometime, whenever we talked about it. When we're talking about brain formation and the ventricles. So we have these ventricles, these openings within the brain. Here's the lateral ventricle here. Here's the third ventricle here. Here's the fourth ventricle. And then we have the cerebral aqueduct. There's fourth ventricle, third ventricle, lateral. Well, they didn't label that. Okay. Well, anyway, in all of these places, we'll have cerebral spinal fluid. And then we'll also have cerebral spinal fluid here, running down the middle of the central canal. But then we'll also have cerebral spinal fluid out here in the subarachnoid space. Okay, when this right here, subarachnoid space, here's the arachnoid mater, there's the dura mater, and then they didn't put pia mater, but that would be touching the brain. So in these red capillary beds right here, that's these right here, this is called a choroid plexus. And the choroid plexus is just a bunch of capillaries that are going to produce cerebral spinal fluid. So now you need the cerebral spinal fluid to be able to circulate freely from the lateral ventricle through this interventricular foramen into the third ventricle, down through the cerebral aqueduct to the fourth ventricle, down through the central canal, and then out here around in the subarachnoid space. And so what it's going to do is float your brain inside of your skull. Now, unfortunately, sometime if you have, and I'm going to go out because I want to see if I've got a spinal cord picture. Ah, that's what I want. Okay. All right. So remember when we looked at spinal cord last week, and I said that when you get to L1, the spinal cord ceases to be spinal cord material right here at the conus medullaris. Right there. Okay, so right here, conus medullaris is the end of the spinal cord, and then we have the cauda equina. So these are just nerve roots that are coming off of the spinal cord, and then when we get down here into like L3, L4, L5, all we have are just nerves. We don't have a solid spinal cord anymore. And because of this, then it lets us do this. So in this particular case, we're doing a lumbar puncture right here, which is where we're going to draw off some of the cerebral spinal fluid in the subarachnoid space. So this is cerebral spinal fluid all in here. That allows the doctor to diagnose if you have some brain infection that we suspect, like meningitis or encephalitis. That allows us to diagnose that by looking to see, do we have any microbes that are present in the cerebral spinal fluid, because we absolutely do not want that in the cerebral spinal fluid. So between L4 and L5, then we will insert a needle here and we'll draw off that cerebral spinal fluid. Now, also in this space, we'll put a needle in if we are doing spinal anesthesia, like in an epidural. So epidural means above the dura. And so in this space right here, we're going to inject the anesthesia, but we're not going to touch the dura. So the dura is this purple layer right here. So we want to inject it right in that space, and then that's going to block the voltage-gated sodium channels so that signals will not be sent anymore. But unfortunately, as in my case, with my second child, when I was delivering my oldest daughter, I had to have a C-section, and so I had to have a spinal anesthesia. So they put the needle in, and so here I'm sitting on the table, I'm big old pregnant, and I'm trying to bend over, because we need you to bend over so that we can open up this space as well as we can, well, this space between the spinous processes of the vertebrae, of the lumbar vertebrae. And so the doctor, he sticks in a needle very similar to this one. It's just not going to go all the way into there. And he goes, oh, what leg did that go down? So what had happened is that in inserting the needle, he had touched one of these nerves. And I said, oh, that went down my left leg. And then he pulls the needle back out a little bit, and then he pushes it in again, and he goes, oh, what leg did it go down this time? And I went, oh, that was my right leg. Well, he did that like 5 times. Okay? It kept sending like electrical shock, like, you know, when you hit your funny bone. Same kind of feeling. And then finally he said, oh, okay, I'm in the right spot. And he put in the anesthesia, and I went numb, and I delivered my baby, and everything was perfect. Everything was great. Anesthesia started wearing off a little bit when they were sewing me back up again. Only the pressure part was wearing off. I still, because prior to that, I didn't feel a thing. But then when they were putting me back together, then I could feel them pulling and tugging and stuff, but there wasn't any pain. With my first was an emergency C-section. I didn't feel a thing. I didn't feel anything. We delivered him. They sewed me back up again. I had nothing. All right. So then I'll tell you my story about my 3rd pregnancy. But we got to do this story first. So let's go back to this picture. And well, okay, let's stay here for a minute, and then we'll talk about. So I delivered her on a Wednesday. That was Wednesday morning I delivered her. And then Thursday morning, lunchtime, somewhere in there, oh my gosh, I had like the worst headache I've ever had in my life. And I thought, well, this is really weird. And why am I getting a headache all of a sudden? And I just thought, oh, you know, I haven't had caffeine for 9 months. I haven't had a soda for 9 months because I don't drink soda when I'm pregnant. And so I thought that was that. And I was miserable. And then I thought, well, maybe I just have a stiff neck, because I realized if I put down the hospital bed, my headache went away. But if I put the hospital bed up so I could watch TV, then I was pretty miserable. So there it was. I went home. They let me go home the next day because I had a 2-year-old at home. I didn't want to be in the hospital anymore. I wanted to get home to him. And so I was doing really well otherwise, and they sent me home. Nobody asked me, do you have a headache? I didn't think to say anything about it. So that was Friday. Saturday morning, I still had this outrageous headache, and my best friend across the street came over. She had just had a baby 8 months before me. And I said, man, Shannon, I got this headache that's just killing me. She goes, oh my gosh, Tammy, you have a spinal headache. And I went, oh, I didn't even think about that. She said, I had a spinal headache when I delivered Michael. And I just was, oh, are you kidding me? So I called my doctor. I said, I have a spinal headache. And he goes, oh, okay, well, here's what I want you to do. I want you to lay down. I want you to drink as much caffeine as you can so that your cerebral spinal fluid will hurry up and build itself back up again. So why did I need to do that? Well, if we go back to, no, it's not going to take us back there. If we go back to our circulation in our brain and this, okay, so what had happened was that way down here, so we'll just go in a different color. Okay, so way down here at L4, L5, the needle poked into my dura right here, and little bits of cerebral spinal fluid were leaking out into my epidural space. And so what that was doing, that when I sat up, then my brain would sag. Okay, because I didn't have as much cerebral spinal fluid as I was supposed to have. So my brain, when I was upright, would sag. When I would lay down, then it was fine. But it was horrible. And so I called the next day because I still was miserable. And so the doctor said, okay, go back to the hospital and tell him to do a blood patch. Tell him you need a blood patch. I'm all, okay. So I go back to the hospital, freaking same anesthesiologist. Oh, there's a little baby with hydrocephalus. We'll talk about that in just a little bit. Same dang anesthesiologist. And he goes, oh, hi. And I said, yeah, hi. I have a spinal headache. You better fix me. And he goes, okay. And so I don't think he even apologized. He just says, okay, here's what we're going to do. We're going to take some blood out of your arm, and then I'm going to shoot it into this space. And he said, you know, so I'm like, are you kidding? You are going back into my back, not on your life. But I had to, that was the only thing. So what they do is they shoot some blood in there, and then it clots, and then it fills up the hole in the dura. So here were the holes in my dura where he had poked, right, all in there. And so then my cerebrospinal fluid was leaking out here, from here. And so 45 minutes later, my headache was gone, and I went home, and it was great. And the reason why I tell you this is for future reference. So ladies, and then gentlemen with your wives, if they have to have a spinal anesthesia, like an epidural or a spinal block, please make sure that after that happens, if they have a headache, don't leave the hospital. There's no reason for you to leave the hospital without a blood patch. I had a student last year tell me, oh yeah, Miss G, I had a baby, and then it was 3 weeks I had a spinal headache before I finally went in and had my blood patch, and then it went right away. I'm like, there is no reason for you to endure that. I endured it for 3 days and thought that I was gonna die. So so make sure you keep that in mind, you know, 5-10 years down the road, whenever you're gonna have babies and stuff, after being in here, no spinal headaches. Get a blood patch. Okay, now we're just real quick. I'll tell you my other story. Oh heavens. All right. No. I'm gonna save that because we haven't talked about that yet. That's after the next test. I'll tell you the story of my third delivery. Okay. So those are those. So let's just go ahead and finish off ventricles of the brain because we already know these. So we'll look at the pictures again, and then we'll do the mid-sagittal section. Actually, I'm going to show you another video before we do that. Ventricles of the brain. Oh, it's up here. Okay, so here again are the ventricles of the brain. We have the 2 lateral ventricles, the 3rd ventricle, the 4th ventricle, cerebral aqueduct. So 2 lateral ventricles, 3rd ventricle, cerebral aqueduct, 4th ventricle, right in here. And then if I go to, and that's it. Okay. So there's those. And then I showed, and then cerebral spinal fluid would then just be all the fluid that's inside of there. And then just to go back to this picture. So here's the choroid plexus. So you've got CSF, that stands for cerebral spinal fluid. Then you have choroid plexus on your list. So there's the choroid plexus of the lateral ventricles. Here's the choroid plexus of the 3rd ventricle, choroid plexus of the 4th ventricle. So like I said, the choroid plexus is just a ball of capillaries. Okay. All right. So let's now go to a subdural hematoma and look at that video. Okay, so I'm gonna sorry, on the chat. You know, a day. So Allegra asked, how long does it take for the puncture to heal? I mean, 45 minutes and that clot was enough to make my headache go away, and then I didn't have any more after that. So it's short. Once you do the blood patch, it doesn't take very long at all for it to heal. But if you don't plug up the hole, then that cerebrospinal fluid keeps leaking out, and and is pushing open any repair that your meninges might be trying to accomplish. So so yeah, so go get a blood patch. Okay. Oh, I know. So now let's go back to our list. And so we're going to look at the subdural hematoma. Okay, I'm just going to warn you right from the outset that this is kind of, there's blood. Okay, so, but whatever. there's just a hematoma, which is a blood clot, big giant blood ball. But I'm just letting you know ahead of time, if you just want to turn away while we're watching this, if you're, if you're planning on, I don't know what you're planning on being in a nurse, but where you might not see this, I don't know. You're going to see everything sometime in all your clinicals and stuff. So anyway, so here's our subdural hematoma. And I'm going to talk over this as we watch it and pause it in certain places. All right. Okay, so we want to talk about the little lady that this happened to. Okay, so subdural means underneath the dura, and it's probably subarachnoid too, so actually in that arachnoid space on top of the brain itself, and you'll see why when we get into more of the video. But so, okay, what list are we on? You mean where I got these videos from, Camilla?
I just was asking from our lab list, do we need to be following along on any certain spot?
No, right now we're just seeing some more about the meninges. So
okay, that's
yeah.
what I thought, but I wanted to make sure I wasn't missing anything.
Yeah,
So
no,
thank you.
no, this subdural hematoma term is not one that you need to know. I'm just showing you more about the meninges.
Okay, thank you.
Yep. Okay. So we have this lady, 83 years old, head trauma. She fell from her height. So in other words, she fell down. Okay, she tripped over something. Probably hit her head, whatever, for this to happen. Now, there is a Glasgow Coma Scale that goes from 0 to 14. And what that means is that there are 4 different things we evaluate you on to see how much of a coma you're in, because you're not just in a coma or you're not. We have like gradations of coma. So 0 is like you're dead. I guess that we would never have a 0. And then 14 is you're awake, you're conscious. So she's pretty good at 9. Her one problem that is really bad, that would have scored her down, is her anisocoria. So anisocoria is when you have a pupil that is fixed and dilated. So here in this case, her pupil, her left pupil, isn't reacting to light. So they're shining the light on it. It's become dilated. It's not moving. It's not reflexive at all. So what is causing that fixed and dilated pupil? Okay, so they did a CT scan of her head. They found the left acute, means it just, sudden onset, subdural hematoma, left uncal herniation. I'll talk about what that is in just a little bit. And then severe intracranial hypertension. So there's a lot of pressure going on in her brain. This is why we have to put shunts in when people have hydrocephalus, which I'll talk a little bit more in just a little bit. And then when we have any bleeds, like a subdural hematoma, we have got to stop the bleed, and we've got to get out that blood as soon as possible. Because if that pressure gets too high, then it's going to push on the brain, it's going to push on the medulla, it's going to stop your breathing, it can affect your heart rate. Just bad stuff is going to happen if we don't take care of that intracranial pressure. So what do we do? In her case, they did a craniotomy. So they're going to open up her cranium and evacuate it and clean out the stuff. So I told you before, my youngest is addicted, absolutely addicted to Grey's Anatomy. And she came in to me one day after she'd probably watched all 16 seasons and 15 seasons up to that point. And she started talking about a craniotomy. And up until this point, my 16-year-old did not talk to me about anatomical stuff at all. She didn't like science, even though she'd always planned on being a nurse. So I'm like, how do you be a nurse when you don't like this stuff? But as she's taken classes, and she's in anatomy at the high school right now, and Grey's Anatomy, so she's kind of warmed up to me. So we talk about stuff. But she came in, she talked to me, she goes, something craniotomy. And I'm like, what are you talking about? She goes, yeah, I saw it on Grey's Anatomy. So thankfully, when we watch Grey's Anatomy together, I get to tell her about what they're doing, and it makes it better. So she's all, okay, I hate the rest of science, but I like medicine. So if you're going to be a nurse, you better like medicine. And then she's all, Mom, am I going to pass your class? When she takes my class, I said, yeah, you'll be fine. Your brother and your sister did, so you'll be all right. So, okay, so what are we going to do with the craniotomy? Here we go. All right. Oh, first, let's look at the CT. So here's our CT. This is the subdural hematoma. All of this right here. That's all blood. Look at what it's doing. Oh, my right or left lateral ventricle is completely gone. It's been squished. Here is that subdural hematoma right there. So we're going to do a craniotomy, which means we're going to have to cut into her skull. So we're removing the scalp. So they're totally taking off the scalp. Okay, so and just folding it back. So now we can see her skull. Here you can see a suture, probably sagittal suture right there. So they drill holes into it, and then they make cuts so they know how deep to go. And then they're going to peel off her skull. And now we have the meninges on top. So here is the meninges. You can't see the actual brain itself. Here are all the meningeal vessels, arteries on there. So they're cutting through the meninges. That shows you just how tough the meninges really are and pretty thick. We're going to peel that back. And then all of this is the blood clot. So that's the hematoma. Now they're going to pull that off. They're going to rinse it away. But the thing I want you to watch is this guy over here that's going to catch it. So the blood just stays all together. Watch, these hands are going to come in right there, and they caught that blood clot. So that's the cool thing about blood clots, you guys, is they're very tightly held together, and so you're able to just slide it right off the surface of the brain. Okay, so here's the meninges. So what we're looking at here is either arachnoid mater or the actual pia mater. I can't tell. This looks a lot like arachnoid mater, but this looks like pia mater over here. So I'm not sure how far beneath the beneath the dura that they've gone. But what I want to show you next is what the bleed is like, because it's still bleeding. Now that the clot is gone, it's going to start bleeding again. So I want to show you the bleed that she's suffering from. Okay, so they're going to go up a little bit closer, but I want to show you right here. So here we've got this artery going over in the sulci. There is the blood that's shooting out of there. That hole is just a pinprick, but enough bled out that it created that hematoma. So look right here. There's the tiny little hole. Okay, and you can see the little tiny hole. Oops, let me pull that back just a hair. All right, so there's the little teeny tiny hole. Here's the blood. So here's what we're going to do. We're going to cauterize that. So we're going to take this cauterizing tool, and we're going to touch the blood vessel right here, right there, which is going to burn the blood vessel shut. Now we're going to evacuate it, and then it stopped bleeding. And then she's better. So then they put everything back, put the meninges back, put the skull back on, staple the skull back to her head and her scalp. All right, so let's look at what the post-op results were. So surgical time, 3 hours. That's not bad. You know, that's a pretty fast surgery for that. Complications, none. Intraoperative bleeding, 200 cc's. That's about, let's see, 16 ounces is 355 milliliters. So about a cup of blood. That's not bad at all. Okay. The patient remained intubated and sedated in the ICU. After a month, the patient began a rehabilitation program. Sequelae are your remaining consequences. So the results, things that didn't work so much anymore. So we have left cranial nerve 3 and right body paresis. So we have some paralysis going on, and then the third cranial nerve also was still affected. So let me show you why the third cranial nerve was affected. So if you remember what the third cranial nerve is, that's the, no, they did not cut her bone away along the suture. So Camilla just asked, did they cut her skull bone away along the sutures? Nope, we're going to cut it not on the sutures, because the sutures are super, super strong. So we want to leave those strong. We're going to cut in other places in the bone. Okay, so no, they did not cut along there. So the third cranial nerve is the ocular motor nerve. so we can get out of this. Okay. So let me show you what, let's see, where is my cranial nerves picture? Okay, well, we can look at this view. All right. So let me stop sharing and then share my new screen. Okay. So here's what happened with this poor little lady. So let's make that just a little thinner and a little more bluish color. All right, so here is her third cranial nerve right here. So where is her, oh, they don't even have that on there. Let me answer this question really quick. Yep, you cut the meninges and then they grow back again. Yeah, I'm sure they probably sutured them back again once we put the meninges back over the top of the brain, because yeah, they'll heal. That's fine. Okay, so here is the cranial nerve number 3. Let me draw a line out from it right there. Okay, so cranial nerve number 3, the ocular motor, is in charge of moving around 4 of the 6 muscles that innervate your eye and for changing your pupil size. So the muscles that are in the iris of your eye, when they change due to light, that reflexive action is going to go in through the ocular motor, it's going to go in through something else and then come out through the ocular motor to change your pupil diameter. So here's what happened. So remember, she had this left subdural hematoma. This is the left, so this is the anterior. Gotta make sure I'm doing this right. So this is anterior right here, posterior. When you're looking at things upside down, it's all backwards. Okay, so this is her left hemisphere. So what happened is she had a left uncle herniation. So as that subdural hematoma on top of her head was pushing, it pushed out the uncus. So that portion of your brain is the uncus. So it pushed it out like this, and then it pressed down on that oculomotor nerve and then affected it. But it was affected long enough that she still had some left cranial nerve, so her left eye was still not moving, probably maybe still fixed and dilated pupil, I don't know, but it says she had the paresis, and so that's motor paralysis, so something still affected that, or the result of that pressure on that nerve damaged it to the point where it still affected her. Okay, so there's that. All right, let's go ahead and finish off the terms then, and then we're going to look at 2 more videos and then we'll be done for today. So we're going to look at the structures in mid-sagittal section. So let me find that view. It's this one right here. All right, so we're going to take a look at this diagram, this upper diagram, to look at the rest of the terms on the list. Okay, so the next thing we want to take a look at are the corpora quadrigemina. So this is, let me get my thing. Okay, so here are the corpora quadrigemina right back here, just above the cerebellum, just below the cerebrum. Corpora quadrigemina, right here. Okay, corpora quadrigemina. Now, on your list, it says superior colliculi and inferior colliculi. So this one right here, that is the superior, and I'll just get a different color. Superior colliculus is one, but you have 4 of these bodies. So 2 on one side, 2 on the other side, because this is split down the middle. And then this one, oh, that's a bad color. Let's just do this one. Okay, so then that one is the inferior colliculus. Okay, so what are these for? Okay, like Hank said in his in the beginning of the video that we watched the other day, the midbrain, so that's where the corpora quadrigemina are. This is where that reflexive, where is that, what's that light coming from? Okay, so this is for vision. So we just get some reflexive vision stuff coming in, like, oh, I'm catching that out of the corner of my eye, and I turn my eye to try to see where that's coming from. And then my inferior is auditory. So that's where we look around to see, well, where's that sound coming from? Okay. So that's going to help regulate that. So superior colliculus, vision, reflexive input and output, and then inferior is auditory input and output there. Okay, so that's corpora quadrigemina. Then we have the pineal body. So here is the pineal body right there. Pineal gland, pineal body, they're the same thing. This is what governs our sleep-wake cycle, because the pineal produces, you've probably heard of this stuff before, melatonin. So this hormone is what makes us sleepy. And so if we don't sleep well, then we can take melatonin and that will help us want to go to sleep. Okay, so the pineal gland is for that. Here is the medulla oblongata. This is our reflexive center for our heart rate, our breathing rate, our blood pressure. Very, very important. Of course, we'll talk more about that in lecture tomorrow. Okay, then we have the pons above that. This is where things cross. So Annette, you asked me yesterday, why do your things cross? Why does the left side control the right side? And it's going to happen at the level of the pons, and we'll talk more about that tomorrow. But the pons is going to be involved in regulating your breathing rate. It's going to be regulating your going to the bathroom reflex. So you're unconscious going to the bathroom reflex, so like babies, and we'll talk more about that later. Let's see, so where are we? Corpus callosum. So the corpus callosum is this structure right here. This is white matter. It's called a commissure, and its job is to connect the two halves of the brain together. Okay, so corpus callosum. And the corpus callosum is very important in coordinating your right hand and your left hand activities together. We will watch a little, maybe because I don't have the link, oh, maybe we'll watch, hang on. I'm trying to decide which ones we're gonna watch. We wanna do the DBS, and then we'll do the split brain thing. So I'll find that split brain video I wanted you to watch. Okay, so so the corpus callosum lets you coordinate left hand, right hand kinds of things, and what you see coming in and deciding which hand does which. Sometimes in really severe epilepsy that doesn't respond to medication, we'll sever the corpus callosum so that we don't have the connections going back and forth between the two halves of the brain to overload your brain. And but then that leaves you with some special characteristics in you, which we'll watch a little video on in just a second. I had a student a couple years ago now say that her daughter was born without a corpus callosum, so there wasn't those connections that go back and forth. And so I said, have you, see, now that you know what the corpus callosum does, can you look back at your daughter's, and she was only like 2 at the time. I said, can you see, delay in her progression and her development, walking and picking things up and those kinds of things? She goes, oh yeah, now I totally do. But she had learned, because our brain is very plastic, and your brain, when you take parts out or parts aren't there, other parts of your brain compensate for that. So her brain was able to adapt to the absence of a corpus callosum, and so she's fine. Okay, now let's just finish off the list, and then I'll decide what we're going to do next. All right, now if we take a look at right here, it says septum pellucidum. So the septum pellucidum is a wall. So I'm going to color it in. So because septum means wall. Okay, but what do we know is this wall covering? Well, what's right here? This is the lateral ventricle. Okay, so I'm going to pull that out and call that lateral ventricle. Oh, that's terrible. Lateral ventricle. Okay, so remember you have 2 lateral ventricles, And so we're just going to put a wall between them to make cerebrospinal fluid stay on one side or the other. So when we can't see into the ventricle, then that's because, oh, excuse me, that's because the septum pellucidum is in place. So here in this picture, we can't see into the lateral ventricle. And so that's the septum pellucidum. But I'm going to try to find a picture where we can in just a minute. So that's septum pellucidum. All right, now the thalamus. So this egg-shaped area right here, okay, that is the thalamus. And then note, I just do that all the time. And notice that it says encloses the third ventricle. So this is depressed in here. There's a depression or an indentation in here. So the wall of the third ventricle is the hypothalamus. Okay, so there will be cerebrospinal fluid in here, but the wall of the cerebrospinal, or of the third ventricle, then is the thalamus. And then the hypothalamus, let's do it in this color. Okay, so here then is the hypothalamus. Okay, because it's below the thalamus. So there is the hypothalamus. So thalamus, this egg-shaped structure, hypothalamus is the darker purple thing. All right, now down here at the bottom of the hypothalamus is the optic chiasma. But I'm going to show you a better picture of the optic chiasma in a minute. I don't want to leave this picture with all my drawings on it and then I have to draw stuff back again. All right, pituitary gland. So here is the pituitary gland, is this thing right here. Okay, so right here is the pituitary and it hangs down from the brain. But what does it hang down with? That is this thing right here, the stem off of the hypothalamus that they didn't label, called the infundibulum. Okay, so the stem of the pituitary gland is the infundibulum. And we talk a lot about the infundibulum in the first part of 202 next semester. Okay, so let's, does anybody have any questions about this picture now that I've drawn all over it like I'm 5? Fabulous. Okay, because that's what it looks like. Hi, my name's Tammy. I'm 4. I like to draw on things. All right, so let's go to this picture right here, and let me show you the optic chiasma. All right, so here you would have an eyeball out here, and you would have an eyeball out here. And then we need an optic nerve that's going to come in from each eyeball. Oh, look. And when it gets in here at the level of the infundibulum, so here, this hole right here is where the infundibulum would be, and then hanging down from it would be the pituitary gland. But they left that in the brain. I mean, in the skull. All right, so here's what happens when our optic nerves come in. They cross, but what you see on with your right eye doesn't just go to the left, and what you see with your left doesn't just go to the right. Here's how it works. So I'm going to take what I see with the right part of my eyeball, and then I'm going to send it this way, and then what I see with this part of my eyeball on the, let's see, no, I'm going to take it from what I see on the, okay, that's right. I'm going to take it down here, and then this is going to go together. And then what I see over here on this side of my eyeball, oops. So right here is going to come in and go down here, and then this is going to come down here and go like that. Okay, so what we have is what we see out of the two sides of our eye. One side both goes to the right side of our brain. What we see out of both sides, the opposite side of the other eye, goes to the other side of our brain. So then we get this crossing right here, but it also gives us depth perception or binocular vision everywhere we look. And so because we're predatory, well, because we're predators, We need to have depth perception so that we know how far to reach out and grab something if we're gonna like kill it or whatever. And so that's why we have the optic chiasma, okay? So that cross right there is the optic chiasma. All right, so that is all of our terms. So which pictures do you need to know for next week? So you should know this meninges not meninges, ventricles picture, okay? And then you should know the meninges pictures. Okay, so those and this one right here. And then we need to know the lobes of the brain and gyri and sulci. So this picture right here. And then the mid-sagittal view of the brain. So this one right here. And yeah, that's all of the pictures that the images will come from on the quiz for next week. All right, so before we leave, let's see, which one do I want to show you? Let's watch the deep brain stimulation one. So that is this one. Oops, so let me unshare. Okay, let me get that loaded. Okay, all right, and then share my screen.
To Roger Frisch, the violin is not just an instrument, it's part of him, an extension of his passion for music, beauty, and excellence. Roger's mastery of the violin has put him on the world stage. Few have reached this level of expertise. But not long ago, Roger noticed something wasn't quite right when he pulled the bow across the strings.
When I would draw my bow, I suddenly had a shake in my bow. Now, for most other professions, this would not be a concern. For being a violinist, where your career depends on the stability of your appendages, this was a great concern.
Roger has what's called essential tremor, a nervous system disorder that causes shaking. Concerned, he went to Mayo Clinic where he met neurosurgeon Dr. Kendall Lee.
The amount of tremor he has would be considered pretty mild, but not in the case of a concert violinist.
Dr. Lee and Roger agreed that deep brain stimulation, or DBS, was their best chance at stopping the tremor. It involved placing electrodes into Roger's brain. But there was a challenge to overcome that created a first ever situation in an operating room. You see, because Roger's tremor was so small, it would be difficult for Dr. Lee and his team to tell if the electrodes they were implanting were in the best possible place to stop the tremor.
And so what we needed a violin in the operating room.
Kevin Bennett heads Mayo Clinic's Division of Engineering. His team worked with Dr. Lee's team to create a violin Roger could play while awake during surgery.
We built and designed a 3-axis accelerometer that we could attach to the bow so that as Mr. Frisch was playing, we could actually see a plot on a computer screen of the movement that really shouldn't be there.
During the procedure, Dr. Lee inserted electrodes into Roger's brain and moved them to the site where the tremor originated. Once there, electrodes fire electrical signals to hopefully stop the tremor. By measuring Roger's movements, the accelerometer told Dr. Lee if the electrodes were in the right spot. There was no guarantee it would work. Thankfully, it did work.
I thought this was a wonderful challenge to see if this technology could help in this sort of a unique situation.
I started playing right away the day I came home from Mayo. I was back playing with my colleagues with Lucid Orchestra 3 weeks later. Without the stimulator on, the tremor is quite pronounced.
You can see the difference. With the click of a controller, Roger can turn the electrodes on and off.
And that's as smooth of a bow as I can play right now.
But when it's on, Roger's mastery of the violin is absolutely clear.
I remain very, very thankful every day that I have had the opportunity to have had this surgery. And, you know, I just do not take it for granted.
Back on the world stage to make music, beauty, and achieve excellence.
All right. Pretty crazy. So that was one of the first times that had been done. But now this guy, that surgeon, that's his thing now, is treating those kinds of tremors and stuff like that with deep brain stimulation. So this second video under deep brain stimulation will be just him talking about that. Okay, so the last thing that I want to show you, I'm going to go find the split brain surgery because I have the wrong link on here. But at your leisure sometime, watch these two videos on prosopagnosia. Really kind of crazy, but I'm not going to show them to you now because they're both about 13 minutes each. So let me just find that video that I wanted that's supposed to go there. Oops. Okay. All right. So,
people working a long time.
wait a minute. Hang on. Let me go back. Okay, this is the one I want. We won't watch all 10 minutes of it. We're just going to watch a little bit at the beginning.
We began our journey into the human brain here on the campus of Dartmouth College in New Hampshire. I'd come to meet one of the world's leading brain scientists, Mike Gazzaniga, and a man he's worked with for over a decade. A man with two brains. People working a long time with Dr. Gazzaniga? 14 or 15 years.
It doesn't seem like that long.
The collaboration began when Joe had surgery. And you had this procedure to correct an epileptic problem, yes. Is that right?
Trying to stop the seizures. I was having seizures like every day, so it's 2 or 3 a day.
To control Joe's epileptic seizures, a surgeon severed the connection between the two halves of his brain. Cutting the corpus callosum like this prevented the spread of the electric storms that caused his seizures. But it also prevented the left and right halves of his brain from communicating with each other. In the years since the operation, Joe's epilepsy has been under control. He now earns a living at an egg farm, and in his everyday life, he's largely unaffected by the fact that his left and his right brains work independently. Do you feel any different when you think about something than you did any differently from the way you felt before the procedure?
It's just got a backup brain, that's all.
That's something everybody could use. I found out how true that was right away when I was asked to draw a different shape with each hand. In a brain like mine, roughly speaking normal, at least all in one piece, the left half of my brain controls the right side of my body, while the right brain controls the left side.
Oh, no.
But because the two halves are connected,
Nothing wrong with that.
getting each hand to work independently isn't easy.
Well, we're seeing the fact that Alan's hemispheres are connected, and that the motor messages from one are confusing the motor messages in the other.
I was just drawing an upside-down duck. Okay. But when Joe is given the same task, his two hands operate as if controlled by two separate brains. What's happening is that each half of Joe's brain is given a separate instruction. He's asked to fix his eyes on the cross in the center of the screen. Anything flashed to the right of the cross goes only to his left hemisphere. Things to the left go to his right hemisphere. Because the two don't communicate, each hand does only what its half of the brain sees. Wow, look at that. It's really like two different people doing the same.
That's right. That's the idea.
Okay, Joe, I want you to keep your hands out in front.
In an experiment that's now a classic in brain research, Mike Gazzaniga over 30 years ago used a similar setup to find out if the two halves of the brain are specialized to do different things.
Ship.
Joe is being flashed a word only to one half of his brain. Words flashed to the right
Storm.
are seen only by his left brain, and Joe can report seeing those words just fine.
Piano. Good.
But when a word is flashed to his right brain,
Didn't see that.
okay.
So I'm going to ask you
But now watch what happens.
to draw that with your left hand. You're going to be lost.
Why don't you try drawing another picture of it over here if that'll help you?
Oh, phone.
Oh, okay. It's almost as though somebody has given him a secret communication.
That's right.
Now he knows that is a telephone. Up until then, he was blind to it.
Exactly.
When Gazzaniga first did this experiment, it instantly proved that the ability to speak resides almost exclusively in the left hemisphere. Not until he sees what his right brain is drawing is Joe able to name it.
He said church, didn't he? After looking at church.
Yeah, but he had to figure it out about as long as we did. That's really interesting. It's a picture here of somebody communicating almost with another person.
The communication is not occurring inside the head, it's occurring out on the piece of paper.
Yeah.
Bob. Wow. You want to draw a little bit more?
So far, Joe has been seeing only one word.
Cat. That's a
Things
cat.
get even stranger when he's flashed two words, each to only one half of his brain.
The right hemisphere saw toad.
Yeah. And so his left hand draws a toad.
So there's the toad.
Oh, it's a toad. And this time I was able to guess what was coming.
Well,
Now put a little three-legged stool in there later, or what? Joe's speaking left brain saw a stool. Saying the word lets the hand that's controlled by his right brain in on the secret. That's great. That's really interesting. And if he had seen that with the corpus callosum intact, he would have drawn a toadstool.
Yeah, I like that part. So if he had seen with the corpus callosum intact, he wouldn't have seen it as a toad in a stool. He'd have seen toadstool, which is a mushroom. And so he would have drawn a mushroom. So anyway, that just shows what happens if your corpus callosum is severed, and apparently it lasts quite some time. I mean, the rest of your life. And but you can learn to adapt. So obviously he can carry out his everyday activities without problem. It's just when he's separated, when we're forcing him to do the tasks independently, that's when they can't be done together. So anyway, just wanted you to see that. I'm going to post that link here in just a minute, and so that you can see that. Just looking out my window, cars driving by. So that's what our quiz will be on then next week. So by Tuesday, will just be our chapter 13 information. We've been through 14 already. We did that last week. And so next week is our last week of lab. Yay. Okay, so we'll be doing the senses. Okay, so eyes and ear parts. And then we'll have the lab practical the week after that. So there it is. Don't have anything else. Anybody have any questions before we leave? Okay, I guess not then. So you guys have a great day, and we'll see you tomorrow at 11 for our regular lecture. Bye.